Thank you very much, Dr. Delfraissy. Ladies and gentlemen, it's a pleasure to be here with you this afternoon. I want to thank the organizers for giving me the opportunity to present on this important topic of the critical challenges in HIV discovery. And for the purposes of the discussion today, I'm going to focus on a cure and a vaccine. Before I start, I would like to dedicate this talk to our lost colleagues from the MH17 tragedy, particularly my dear friend and colleague, Dr. Joep Lang. First, let's take a look at the current status before I get into the critical areas of discovery of the global pandemic. These numbers have just come out a few days ago. As you can see, they are quite impressive, with 78 million people totally being infected, 35 million people living with HIV, and now 2.1 million new infections in 2013. Now, the science up to now has been nothing short of breathtaking, with so much accomplished in areas that we're all familiar with. Probably the most impressive of these is in the arena of treatment, where through basic applied science, which then has led to the development of drugs, we now have in our armamentarium about 30+ drugs, which when used in combination have transformed the lives of HIV-infected individuals to the point when we go back to this slide, we see now that over the past now almost 10 years, there has been about a 35% decrease in the number of deaths due to HIV infection. When we go back to the slide and look at the advances over the last 30+ years in prevention, particularly in the arena of combination prevention modalities, ranging from simple things such as condom use and clean syringes to medically involved situations where you're dealing with microbicides, pre-exposure prophylaxis, circumcision, prevention of mother-to-child transmission, and most importantly, treatment as prevention, we actually see prevention having a major impact on this particular data slide, with almost a 40% decrease in new infections since 2001. This has allowed many of us, in fact, probably everyone in this room, to think aspirationally about the possibility of a world without AIDS. So if you look at how we got to be able to even imagine a world without AIDS, it essentially relates to what I've told you over the previous couple of minutes. The extraordinary advances in treatment and prevention that allowed us to at least consider that we will get there within a reasonable period of time. But critical challenges remain, and I want to discuss two of these that are of great importance to get us and keep us in that goal. The first is a cure. So let me start off by something that I think is very important. We need to define what we mean by a cure. In my mind, and in the mind of many, it is the permanent remission of disease following cessation of therapy. Now, with most infectious diseases, this classically means eradication of the microbe. However, with other diseases such as cancers, this more classically means the absence of relapse, hopefully for life, but for a defined period of time, which through experience, historical experience, we've been able to determine by using surrogate markers. Let me give you an example. When one thinks of a typical bacterial pneumonia, you can actually be sure of a cure literally within days. What happens? The chest x-ray clears, the culture is gone, and the fever is gone. Things become more complicated with neoplasms. Shown on the lower left is a follicular lymphoma PET scan showing the malignant hyperplastic nodes. Following chemotherapy and radiation, they disappear. We know historically now, following thousands and thousands of patients, that after 5 years, if disease does not relapse, you can confidently call this a cure. Now, when you talk about biomarkers, we have terrific biomarkers for plasma viremia. We know when we're suppressing virus replication that's measurable. What has eluded us, even though we have good PCR and we have replication competent assays, is the reservoir which we know is sequestered and is often outside of the availability of what we can access. So we have a critical need for biomarkers regarding the reservoir. And thus with HIV, today, we do not know the time frame from the cessation of antiretroviral therapy to the point where we can be confident that an HIV-infected person is cured. And I'm going to get back to that in a moment. So let's take a look at this reservoir that we've all been talking about over the past couple of days and several years. We know from studies that go back to the 90s that when cells are infected, about 99% or so die, but a small percentage, sometimes less than 1%, are infected. They don't express viral proteins, and they're referred to as latently infected cells, which form the basis of the reservoir. Now, I tend to look at the reservoir because it's much more complicated than most people think. I know people in this room are aware of that, but I like to look at the reservoir in two buckets. One is qualitative and one is quantitative. From a qualitative standpoint, one must consider body compartment, cell type, and the status of the virus. So let's mine down into that for a moment. With regard to body compartment, there's the gut-associated lymphoid tissue, peripheral lymphoid tissue, including blood, brain, and other possible sequestered sites. It gets even more complicated because the cell types are many. We talk often about the prototypical reservoir cell, a central memory cell, but there are also effector memory, transitional memory, naive cells, the elusive monocyte macrophage in the tissue and in the blood, and also virus trapped in follicular dendritic cells. And then we get to the status of the virus. We knew from Jintanat's very nice presentation this morning about the relatively small proportion that's actually replication-competent virus. All of these things confound how we look at the reservoir. There are also quantitative issues. We know from studies from my lab and a number of other laboratories that the time from when a person gets infected to when you initiate therapy determines the initial baseline size of the reservoir. You treat somebody very early, they have a small reservoir. You wait a year or 2 or 3 to treat them, their reservoir is rather large. And if you're going to suppress it, this becomes relevant. Some other facts about the reservoir. We knew from studies that we did years ago that following acute infection, the reservoir is established very early. A paper came out yesterday from Dan Baruch and Nelson Michael and others that showed in an animal model it occurs so early even before there's detectable viremia. So that's something we need to deal with. It's formed very early. We know from a number of studies that even after years of suppression of viremia, replication-competent inducible virus remains. We know that when we stop therapy empirically in most individuals, even after years of suppression, the virus almost invariably rebounds, usually within a period of a couple of weeks. And we also know, shown on this slide, that we did when we suppressed individuals for up to 9 years. When we stopped therapy, the rebound of virus in red was followed by, and there was a reservoir in the blue bar that was below detectable level, if in fact you use replication-competent virus. But following the return of viremia, almost immediately, the reservoir was reestablished. So this is a recalcitrant foe. So how do we deal with it? 2 possible ways that many investigators have been pursuing. 1, eradicate, 2, control. So let's take a look at eradication. We've heard studies about flushing out the virus, and we found thus far you can shock, but you can't kill. What about immunotoxic therapies? Gets rid of some cells, but not all. We have the N equals 1 of the Berlin patient with the Delta 32 CCR5 allogeneic transplant. However, transplants that did not have the Delta 32 from the Boston cohort, those 2 patients relapsed. So it isn't allogeneic transplantation alone. Elegant studies from Carl June and others in editing in vitro or ex vivo and reinfusing cells have shown some interesting data, but it's too early to tell where that will go. When I talk about reservoirs and I talk about trying to have suppression that's prolonged, I use the terminology stacking the deck in our favor for eradication. What does that mean? That means treating as early as possible. And the epitome of that for us most recently has been the Mississippi baby, which we're all familiar with, who was treated within 30 hours of birth from an infected mother who was not treated, received 18 months of therapy, discontinued, and the baby went for a considerable period of time, 27 months and age 46 months of age, before, sadly and with great disappointment, virus that had not been detectable in the blood in a replication competent way actually rebound in an unequivocal way. There are disappointments there, but some very important questions that this raises, such as, since there was no detectable HIV-specific immune response, what was the mechanism that kept this virus suppressed for 27 months? What was the effect of the initial infection that occurred in the presence of placentally transferred antibody? Now, were there defective viruses that were there that over a period of time stochastically recombined into a replication-competent virus? We don't know that. What triggered the rebound? From what cell type or body compartment did it come? There is a study that we're now reevaluating that will likely go ahead, making sure that we have the proper ethical considerations to try and recreate that and ask those important questions. Because although disappointing, the Mississippi baby was a prolonged, sustained virological remission. Not indefinite, but this is something that is an advance. How do you link baby studies with adult studies? If you want to have sustained remission, there should be some commonalities. And they are early initiation of therapy, a favorable quantitative and qualitative aspect of the reservoir, and hopefully preservation, relatively speaking, of immune function. So let's get to a more realistic approach that is really quite exciting when you think about it. The control of viral rebound, or what I'm referring to as sustained virological remission. The Visconti cohort gives us some interesting insight. 14 individuals who were treated during acute infection have now gone for a considerable period of time and are referred to as post-treatment controllers. It is likely that a very special subset of cells have been infected and formed their reservoir. However, on the sobering side, the Boston study, in which patients were treated acutely, stopped therapy, rebound, and then were suppressed, a 4-year follow-up from Bruce Walker's cohort showed that this viral suppression was limited in duration. So we still have a long way to go. I tend to think about post-treatment control in the following way. If you early suppress virus and then get to a point where you can discontinue therapy, what is it that's going to keep the virus under sustained virological remission? It could be natural HIV-specific immunity, perhaps that we did not measure in the Mississippi baby, what we're seeing perhaps in the Visconti cohort. But a number of studies are now planned and are actually being executed. Jin spoke about that this morning, and that is either passive transfer of HIV-specific antibodies and or therapeutic vaccination. Hopefully, a combination of one or more of those will lead to sustained control of viremia in a larger number of individuals. At the end of the day, if you look at how we want to characterize a cure, or let's call it better, a sustained remission, it needs to be simple, it needs to be safe, and not worse than the current treatment for an individual, and it needs to be scalable and not applicable to just a few people. Let me move on now to a vaccine. Again, an exciting area that is problematic in some respects. As an infectious disease person involved in vaccinology now for over 3 decades, the classic paradigm is if you want to develop a vaccine, mimic the response to natural infection. HIV vaccinology has a big challenge. We need to do better. Why? Because HIV is different. Without antiretroviral therapy, unlike most any other virus, it progresses invariably. We get autologous neutralizing antibodies, but curiously only after several months, and guess what? They don't adequately control the viremia. We do get broadly reactive neutralizing antibodies, but again, curiously, it takes about 2 years to develop, and usually in a minority of individuals, about 20%. The virus is never completely cleared, and interestingly and somewhat ominously, there's no protective immunity against superinfection. Now, vaccine approaches have been done since 1987, when we did the first time when we injected a monomeric envelope into an individual, hoping that we would get neutralizing antibody. We didn't. Empirically, the field went on in 2 phase 3 trials trying to induce antibody. which was certainly easy to do, but it was only against lab-adapted strain, and they failed. The field switched over to a T-cell approach, saying, well, maybe we can't prevent infection, but perhaps we can control viremia. That also was not successful. But in the midst of all this, an empiric trial that some actually felt should not have been done, which was a prime with a pox vector expressing inserts of HIV, followed by a protein boost, led to the first signal of efficacy, now well known as RV144 or the TIE trial, which was 31% effective, but taught us something that really made us become quite humble and modest. Namely, we had protection, but it was not associated with broadly neutralizing antibody. It was weakly or non-neutralizing antibody with no discernible T-cell responses to an area of the envelope that you would not have predicted, namely the V1, V2 variable regions of the HIV envelope. Which brings me now to where the field has focused, the gold standard, broadly neutralizing antibodies. Now, we learn about that from interesting what we call experiments of nature. We know from following HIV-infected individuals that a minority of them make antibodies that are actually broadly neutralizing. And what they do, that they recognize what we call vulnerable sites or neutralizing epitopes on the HIV trimer. And they're shown here on this slide. In fact, neutralizing antibodies have been isolated against each of these sites. We know them, they're very well described in the literature. The question is, before we even think about a vaccine, if you take those broadly neutralizing antibodies, can they actually prevent infection or can they be used to treat infection? And the scheme that I've shown on this slide is actually being implemented as we speak. So let's talk about first asking the proof of concept question. If you deliver the antibody, either by passive transfer or vector-based expression, as David Baltimore and Phil Johnson and others have done, can you actually protect or treat? And in mouse and non-human primate models, the answer is yes. So the next question is, and studies are underway or becoming planning right now, can we do this in humans? So if the answer remains yes, then the real challenge is inducing these broadly neutralizing antibodies. So the fundamental challenge right now in HIV vaccinology is how do you take those neutralizing epitopes that we've identified on the HIV trimer, put them in the form of an immunogen which will induce these antibodies, which brings us to a concept that is now the focal point of broadly neutralizing antibody induction, and that's called B-cell lineage HIV vaccine design. What do I mean by that? If you look at B-cell lineage in general, you start off with immature germline cells, the unmutated common ancestor, and as shown on this slide, if you hypothetically take an HIV envelope trimer, what you want to do is coax it along in differentiation, which is going to be associated with increased somatic mutations, the depth and breadth of affinity maturation, and even things like we refer to of a long CDRH3, which is actually just the business end of the binding antibody that negotiates or navigates itself around glycans and other conformational obstacles to getting to the epitope. Lucky for us, there has been an experiment of nature which has focused now on things that we thought might be insurmountable. The challenges are, okay, we have neutralizing epitopes. However, they're not readily recognized by germline B cells. That's a challenge. Not always, but rarely. Certain antibodies are autoreactive. Bart Haynes has shown that, rendering them possibly to clonal deletion before they even get out of the box. There's a high degree of somatic mutation that's required, which is likely why you need years of viremia to stimulate to ultimately get a broadly neutralizing antibody. And there are essential structural elements like the long CDH3 that are required. The experiment of nature that Bart Haynes actually observed and really did follow up to some very important observations was an individual who was acutely infected, in which they had the opportunity to observe the coevolution of the mutating virus as the antibody continued to selectively push it, to the point where at the end of a couple of years, what you had was a broadly neutralizing antibody that was highly mutated, long CDRH3, and broad and deep neutralization. Unfortunately, it did not neutralize the patient's antibody, virus. However, importantly, this is now the roadmap to immunogen design and implementation. Namely, go back to the paradigm of mimicking infection, but truncate it from 2 years to hopefully a manageable time, where you have iterative immunogen stimulation, not the same immunogen with multiple boosts, but engage the B-cell lineage early on, push it to the next stage, and then push it the same way the virus does. This is being very actively pursued by a number of laboratories. Now, I can't conclude about vaccinology without making the very important point that T-cell vaccine approaches, although they failed, as it were, early on, does not mean that T-cells will not be important. They certainly provide broad help for B-cells. They're important as T follicular cells, which actually are important in inducing potency and affinity. They produce antiviral cytokines. They induce help to CD8 cells, and those CD8 positive cells, as we know from the work of Lou Picker and others, can actually kill HIV-infected cells and might be important as we go towards a, quote, cure. And so, up to the point of a cure and a vaccine, I've mentioned to you that the advances, the breathtaking advances in treatment and prevention, had allowed us to be able to at least consider the possibility of a world without AIDS. But we want that to be durable. And if even we can cure or even say induce sustained remission in a reasonable proportion of people, that will greatly enhance the treatment armamentarium. If we add a vaccine to our combination prevention, and with both of these, we may wind up not only with the possibility of a world without AIDS, but a durable world without AIDS, so that now our generation, those of us in this room, may be able to see it happen, and the next generation, my own children, I have 3 daughters, 27, 25, and 22, they have never seen a world without AIDS. So perhaps if we attain these critical advances in science, they'll be able to tell their children about a world that once had AIDS that no longer does. Thank you.